Should we get started? Okay. Okay, we're gonna get started. We'll let people trickle in if they're coming. So, as I said, do the QR code survey if you can. We had a little snafu with the codes in here, so we're gonna have you ignore most of the QR codes on our slides unless we tell you otherwise. Okay. Can everyone hear? Okay. Okay. So just to get started, my name is Madeline Rennie. I'm a pediatric emergency medicine physician and a medical toxicologist at Mount Sinai in New York City. You guys want to introduce yourself?
I'm Steve Standovich. I'm one of the peds emergency med docs out in Penn State.
I'm Chris Burrish. I'm a pediatrician and emergency medicine doctor at the University of Washington and Seattle Children's Hospital.
Okay, and we're all members of the PECARN Adolescent Opioid Use Disorder Interest Group. Here's our disclosures. So the objectives today are to understand the importance of identifying and treating adolescents with opioid use disorder, discuss the conceptual framework for developing protocols for adolescent opioid use disorder, and examine barriers and facilitators for implementing these protocols. We're hoping kind of as a group together, you can help us to inform some directions for future work in this area. So just to get started, it's important to understand the scope of the problem and why it's important. And so about every 2 weeks, one full classroom of adolescents in the US dies from an opioid overdose. And and fatalities have really risen drastically in the last several years, predominantly from illicitly manufactured fentanyl. Many of these adolescents have seen a doctor within weeks of their deaths, really demonstrating that there is opportunity for intervention and potentially prevention of the death. And then there are medications for opioid use disorder, most often buprenorphine. And we know that buprenorphine in adults decreases mortality by 50%. And there's good studies in youth and adolescents that increases retention and care. However, very few children and adolescents get access to any substance use disorder treatment, and even less access to medications for opioid use disorder, such as buprenorphine. And a recent study showed that the rates for youth, really 10 to 24 years old, the rates of buprenorphine prescribing are actually decreasing, predominantly in that older age group, but in the younger adolescents, really the rates of prescribing are very, very low. And many prescribers are uncomfortable treating adolescents with opioid use disorder and treating them with buprenorphine.
So with that background, one of the things we wanted to do was understand how we're treating kids for opioid use disorder and what are a lot of those barriers and facilitators for treating kids. Quick show of hands, who works in the PZD? Great, so about half of us maybe. Out of those that work in the PZD, how many have prescribed buprenorphine? So a couple. So one of the things that we're running into is that buprenorphine has been commonly used in the adult world for quite a while, and a lot of our adult emergency medicine colleagues are quite comfortable with it. It's taken a lot to push that to the pediatric world and to get our peds colleagues comfortable doing it. So one of the ideas with the PECARN interest group is trying to figure out from an implementation science standpoint, how do we get our pediatric emergency medicine colleagues comfortable, or at least doing it. So prescribing buprenorphine, screening kids, getting kids started, inducing in the ED. How do we get that process to happen? One of the issues that we ran into is that there's not a lot of great data on how to do that. So our first step is really trying to understand what our current practices are and what is the expert opinion. The way we're doing that is what's called a nominal group technique, somewhat similar to a Delphi procedure. The reason we're using it is because, like I said, there's limited evidence in pediatrics, and the way it works is you have a structured method to build consensus. So one of the nice things about this is it was virtual. It had our all of the folks in the session. There were 2 sessions, each was about 2 hours long, and there were both structured and unstructured segments to the whole process. So it allowed both our introverted colleagues and our extroverted colleagues to get their thoughts in and try to get a sense of what were the overall issues with prescribing buprenorphine to kids. We weren't sure exactly what we were going to come up with when we went into the procedure. Initially, we were thinking we were going to come up with these are the doses, these are the COW scores, this is exactly how you do it. What ended up coming out was a little bit more of a top-down framework on how you build your own protocol, the types of things that you need to consider as you're building the protocol for your individual institution. And when we go over our results, some of those themes are the things that we want you guys to think about as you're building those protocols for yourselves. So who were our participants? So participants were pulled from a wide variety of areas. We started with the people in the PECARN interest group. And from there, it was basically word of mouth, talking to colleagues, trying to get as many people in the field that were what were considered experts in the field to come in and join with this procedure. We had people from adult EM, peds EM, community peds talks, adolescent medicine and child psych, and people from across the country. So the first step, you absolutely do not need to read everything on here, but it was almost a round robin of going around this virtual Zoom room and putting out these little sticky notes of what you thought was the most important thing for you for adolescent opiate use disorder. There was no right, wrong answer. It was just what are your most important topics that you wanted to talk about. After we got all of the sticky notes up on the board, we spent quite a while color coding everything, organizing everything, trying to put everything into themes, trying to understand what things felt they were in similar type of groups. And then we went through and we ranked them all. Each member had 5 different votes, and we just voted on which cards we thought were most important. And out of that, we were able to build themes to analyze, to figure out what were the most important concepts when building these programs.
And so this was really a great process to go through. It was a lot of fun to hang out with some like-minded people, and we came up with some things that I think are kind of bedrock things that ought to happen when you're considering putting together a protocol like this. And so, first of all, we want to recognize that this is an urgent problem. There's literally kids dying every single day from this, and so. Part of the reason that took this approach was that we don't feel like we have time to do sort of the traditional science that takes forever. We wanted to get expert consensus to start doing this right away. We thought we needed some clinical practice guidelines in order to set up sort of a standard or a goal to shoot for, as well as implementation strategies to get to those goals. We wanted to focus on early identification of kids with opioid use disorder and harm reduction strategies for kids with opioid use disorder and kids with just occasional opioid use who both are at high risk. We've talked about the importance of community care, continuity of care, and transition from the emergency department back to the community in order to have ongoing care for these kids. And talked a lot about all the social and structural barriers that kind of impair this work and that stop this from happening. And it is true, I think that in adult emergency medicine, we've sort of embraced this idea. I think in addiction medicine, we've sort of embraced this idea. The pediatricians really are kind of the laggards, to be honest with you. And because there are some real social barriers and some stigma associated with this, and it's really felt to be an adult problem. And so then the other thing that we just really wanted to emphasize was the importance of collecting data to do CQI, right? So if we're going to ask people to do this stuff, we want to prove to those people, we want to prove to our patients, we want to prove to the administrators that this is worth doing, this is effective. And so we took all of those multicolored cards and we just turned it into this sort of infographic. Just talking about how underlying everything is the idea that adolescents are different than adults, right? They're not just little adults. They've got their own needs. Adolescent kind of care and follow-up looks very different than it does in the adult world. Trying to get adolescents to engage in traditional kind of treatment programs just doesn't work well, right? They don't identify that way. You need community trust and engagement. And these protocols have to be able to be adapted for different geographical contexts, right? Every state has different laws. Every hospital has different policies around this. And so what works in one place isn't necessarily going to work in another. So these protocols have to be adaptable. We need the data to demonstrate this value. And then harm reduction really has to be centered in whatever we do, right? Just trying to, most people who use drugs will recover from their drug use, right? 75% of people who have an addiction will eventually recover from their drug use. We just have to keep them alive long enough to do it, right? So harm reduction is really critical in this work. and then coming up with specific protocols about and recommendations around screening and treatment and supporting providers in making this change, and then also recommendations around how to transition these kids from the emergency department or the hospital to the community, and with some continuity. And so these are the QR codes that don't work. Don't scan these, but we have them on your paper here. And so what we would love to hear from you is sort of, we want a temperature check. Like, does this seem like this is going to work? Specifically, what we're interested in is what are things that you think where you work are going to would make something like this hard to implement? And what are things you think would make it easy to implement? And so you can scan that code. That we have some other questions. And so we'll share some of the results with you here as they come in. And so here's some what are some facilitators? Are there, strong culture of change in your emergency department, commitment to addressing public health crises, clinical champions. And then are there other things that we should be thinking about? Right. I think that we did get a great group of people. I was really excited to be included in this group because they're people that I really admire. And it was awesome. But I'm sure we didn't think of everything. And so are there other things that we should be considering as we do this work? And do you want to talk about some results?
Yeah. Are people still doing the survey? Okay. I'm just going to give 1 minute just because we only have 9 minutes left and we want to make sure we can have a good discussion. So if anyone needs a sheet, just pass it to your neighbor. And I'll give it 1 minute and then I'll go over some of the results.
And one last thing while we're waiting for the results to come in. Like I said, this is work being done out of the PECARN Opiate Use Interest Group. We are focused on opiates, but also all other substances and anything related to substance use in pediatrics. We have PEDSM docs, we have community docs, we have lots of different kind of folks in the group. If you want to join our group, let us know. I'll have a form up here on the iPad. If you want to join, just jot down your email address. We are welcoming to anyone who has any interest.
The reason we're collecting some of this feedback is the next step then is to take this feedback, get together with a bunch of experts, and come up with really specific protocol recommendations, right? I think what we have here is kind of the underpinning or the conceptual framework with which we want to build the protocol. But now we got to actually do the work, right? We got to figure out, like, what's the COW score that we started at? What dose are we going to start at? And so that, the feedback you're giving us is going to help us sort that out and try and do that in a way that is implementable and tolerable for everybody. So what are some of the, I know you guys have probably put some stuff in the chat.
Yeah, so I'll just read out just some of the top, we don't have that many people, but some of the top responses in terms of, thank you for responding, 18 people, I appreciate it. So let's see, in terms of barriers, it looks like, I need to be able to see this better. Social or structural factors was most commonly found to be a barrier, as well as lack of follow-up and identification of opioid use disorder. So maybe we can touch on that to start.
Yeah, anybody want to talk about some of those things and how that might be difficult where you work? Yeah.
I'm from Greenville, South Carolina, and where I'm from, we're very reluctant to, especially parents, to acknowledge that their kids may be using substances. And if they get that far, the next step would not necessarily be a medication to treat it. It would be, oh my God, my child is never touching drugs again, etc. We have tried to push to get Narcan in the schools, and it's very much that doesn't happen here. We're not the type of people that do that attitude. So I think parents would be our biggest barrier.
Yeah, that is so difficult. Does anybody else run into that working with kids? That happens where I work sometimes too, and it's so hard to really kind of say, hey, look, we all want your kid to live. Okay, like and to have that discussion, and they're like, we're not, I'm not putting my kid's not going to be a junkie. I'm not going to put him on this medicine. It's just substituting one medicine for another. And so, maybe having something some kind of suggested, some talking points maybe would be good.
And stigma is intense and very real
Yeah.
in many different populations, and trying to figure out what are those issues that are kind of leading to that stigma of the family, and how do you kind of get through to the family. I also think of it as those conversations are, you just have to keep having them again and again and again. Same as like with any issue with addiction, you're not going to fix it with one visit. It's not a one done type of thing. It's that every time you talk to these kids and every time you talk to these families, a little bit, trying to push a little bit, trying to change hearts and minds a little bit at a time. So unfortunately, there is no great fix. Just trying to reduce that stigma as much as possible. It's not a poor person thing. It's not a XYZ thing. It's an everyone thing.
Yeah, I think one of the conversations I have with our family colleagues often is, hey, look, these kids have, we know that adults that survive a non-fatal overdose have a 1-year mortality between like 5 and up to 15% in some cases, which makes them literally the sickest kid in the whole pediatric emergency department, right? Like bronchiolitis, asthma, none of the other things we see have that kind of mortality rate. And so, really kind of hammer home, this is really critical to address this population. This is the most sick kid in the emergency department. And I sometimes have that discussion with adults, with the parents too, right? The kids, I think, when you're like, you have a 5% chance of being dead in a year, they're like, whatever, it's not gonna happen to me. I don't think that works at all. But with adults, sometimes if you have some of those conversations, say, look, we just want to keep the kid alive. This is FDA-approved medication for this very, very serious condition. Yeah. What other?
Any other barriers that anyone wants to bring up?
Yeah.
I'm Kim from Providence, Rhode Island. I think, as you mentioned, we have the perception that this is an adult problem, and there are a lot of gateway substances that I don't think we have good screening tools and identification of what population we should really focus on, and I think it's going to be really important to be able to figure that out in order to know who we should be, who are those at greatest risk.
That's absolutely true. I think we don't know we don't have a lot of data around how to screen well in this population, and I think it's also hard, like, who's going to do the screening. I think I know ASAP is coming up with some recommendations, but trying to get, like when we started doing suicide screening in our PPD, everyone's like, oh man, it's like one more thing we got to do, right? And so trying to get people to do it and do it buy-in is tricky.
I think you're kind of touched on two things. One is from a science standpoint, who should we screen? Should we screen everyone? Should we screen high-risk groups? What are those high-risk groups? And we're trying to do some data pulling to try to figure out the science aspect of it. Like, in an ideal world, what is the ideal state? I think the other side of your point, though, is the implementation science side of it. Like, once we know what we should be doing, how do we get folks to do it? How do we do that screening? How do we get it to happen as accurate as possible? And that's the more difficult part, I think, is trying to get people to get on board what we know works once we can figure out what that is. Is that global screening? Is it targeted screening? And what is the best screening tool? There are multiple screening tools out there that people have done great work on. But how do we implement those into our busy emergency room settings and procedures?
Yeah, that's a real barrier.
Given our limited time, I just want to highlight some of the facilitators that came out here. So a sense of urgency, I think we all feel that, having a clinical champion, and then responsiveness to the public health crisis. And then when we asked about how feasible it would be to kind of do this where you work, majority of people put a 4. What was 4? To see what 4 was. Yeah, I was like, just want to make sure I was doing the right. Yeah, so 4 out of 5 as it was feasible. So I think that's really promising, that you guys are here and feel like you can make it work. I think we have some ways that we're going to get there.
Yeah. Yeah. I mean, we do live in a time where we have access to tools that we've never had before, that we know work well, or we had them, we've never deployed them well. And so we have the ability to really bend the curve here if we just figure out how to use these things. It's great that people feel like we can do this. And I think if you do this at your place, do your best to share success stories with people, be that clinical champion that shares good news with people, right? I think bad news is all around us all the time, and so we have a couple of kids that do well on this medicine, and I think it's very important to share that with the colleagues.
And we're working on collecting as many written protocols on how to induce buprenorphine at the moment and trying to do a Delphi procedure, trying to figure out what is the best protocol. That being said, if you are at a place and want to start up your own program, there's a lot of information out there, but you can absolutely reach out to any of us and we can help you kind of go through that process of setting up an implementation process at your specific shop.
And this QR code does work, I believe. There's a few protocols in there if you're interested. And I think we are out of time. But it looks like people really put in some very useful specific barriers and other ideas to be included in our work. And we will feed that back to our group and hopefully have more to share with you very soon in the future or next year.
Thanks for coming.